Good morning and welcome to the Formfast web seminar featuring Phelps County Regional Medical Center. My name is Laura DeVries and I am the host for today's session. I would like to welcome you as we learn and discuss ARRA funding initiatives and the journey to Stage 7 of the EMR adoption model. Today's session will be an interactive forum and will include Dave Dowdy, CIO and Administrative Director at Phelps County Regional Medical Center, Joe Abbott, Assistant Director of Applications and Technical Support, Vicki Dixon, Director of Materials Management, Melissa Blanton, Forms Coordinator, Sharon Clayton, Director of HIM, and Pam Feeler, Director of Nursing Informatics. The panel of speakers will field questions from our audience in an open Q&A forum. Phelps County is a 242-bed facility located in Rolla, Missouri. They have recently achieved Stage 6 of the EMR adoption and are moving forward towards Stage 7, which is the most comprehensive level of usage identified by the HIMSS Analytics EMR adoption model. This accomplishment puts Phelps County into an elite group of U.S. hospitals with only 1.8% of hospitals attaining this level of adoption. It is my pleasure to introduce today's forum moderator, Sean Curtis, Director of Product Marketing at Formfast. Sean, at this time, I'd like to turn it over to you.
Thank you very much. So to get us started, I'm going to start with Dave again, and just give us a little bit of background about Phelps Hospital and what your region, what your services are, the size, general demographics of your hospital.
Okay, we're a community-based hospital, of course, in South Central Missouri. We do most everything. We just came from a leadership team meeting earlier this morning where our psychiatric department presented some of the solutions that they provide. We provide both inpatient and outpatient services in that arena. Certainly have a lot of outpatient surgery activities. Inpatient, we cover most all the gamuts of the community hospitals. We probably are the primary healthcare organization, certainly within 100 miles of any other hospitals and clinics. So very, very busy emergency department. We have adopted Meditech, of course, for about 10 years now and implemented the products and use most all of the Meditech modules across the board. We're very heavily CPOE based. We love that fact and discovered over the weekend that our actual physician order entry is even higher than the numbers actually show. So we're happy about that. The organization has supported 100% CPOE since last August when the MEC and the board decided that January 1, 2010 would be the turning point where we wanted all of our providers to use CPOE. So we've worked toward that goal. Certainly it isn't a magic 100% effective one day, but the last 5+ months we've worked very hard to accomplish more and more of the CPOE picture. And of course, when you do that, you really build in using all of the electronic opportunities within the product that you use as well.
Okay, great. And so, primarily we're here to talk about your Stage 6 achievement. And can you tell us a little bit about Stage 6 achievement, when you were actually validated by HIMSS, and your process of getting there to the group?
It's pretty easy. Phelps worked hard all during that period of time of Meditech implementation, and we finally reached a point where we were just using so much of the product or the products across the organization that when it came time to participate in the HIMSS survey, I really didn't even know about the MRAM levels. I hadn't thought about them, wasn't tremendously exposed. We just completed the survey. And as a result of the survey, we began to see some of the analytics that come out of HIMSS and began to recognize that, gee, we're doing pretty well compared to other organizations. So we looked at some of these charts, and I used them in administrative presentations, but it began to dawn on me that So many of these organizations were being presented as HIMSS Stage 6 organizations, and I thought, we've got to be there. We've got to be pretty close. So called HIMSS, and through several conversations and several queries and lots of questions, in approximately February 2009, HIMSS says, well, gee, yeah, you are Stage 6. So we were all very happy and certainly had a big feeling of relaxation at that point in time, and participated in the HIMSS 2009 awards.
So what do you think was the biggest challenge of achieving Stage 6? And even though it was a parallel to what you were already doing, was there a gap between what you were doing and what Stage 6 actually represented?
I don't think there was a real big gap there, because Stage 6, if you're familiar with the MRAM model, that presents all of the things that you want to do when you're looking at these products, whether they be Meditech or anything else. So what we did is follow the implementation guideline based on administration setting the priorities. And I think that based on those needs, we happen to fit into that HIMSS model. We didn't do the HIMSS, as I indicated earlier, because, gee, we saw this big award. We just worked through the implementation of the modules and had the foresight of administration and the support of administration to really point us in the right direction and to be at a point where we satisfied the HIMSS guide.
So looking at the chart that I have up there from HIMSS Analytics, it shows that there's only about 1.8% of the population of hospitals in the country are at Stage 6, and that's a pretty elite group. But what do you think is keeping others from being there, especially if you did this primarily as just following your business plan? What do you think is holding back, or what are the challenges that other hospitals might have?
Challenges that other hospitals might have. I think if they have challenges, it probably existed for a while, probably the financial side of it. I've noticed, this is Joe, by the way, as these surveys have come in over the past few years, it seems like staffing in an IT department tends to be very thin, especially at small hospitals. I think in the past, a few years ago, internally we would even get sort of dinged by some managers having too much staff in the IT department, because they would see in the survey results that other hospitals might have only 2 or 3 IT staff members. Well, certainly if you've got 2 or 3 IT staff members, you're not doing the big initiatives. I mean, you're not going to be in a position to implement Meditech or implement any other CHIS system. So I think staffing, I think having the financial support of your organization, and then I guess just again, if you're not at Stage 6 at this point, or Stage 5, if you're sort of towards the bottom part of that scale, then internally you'd have to look at creating some awareness and some motivation with your CEO and CFO and at that level of management in the hospital, I think.
So when did you start your trek towards this EMR adoption? And then, a follow-up question to what you said, Joe, is what did your IT staffing look like at that point, and what does it look like today?
Okay, well, I've been here 5 years, and I have a timeline that I've used in presentations before, so I can go in some detail. I'll go quickly down this timeline, though. Our board of directors, excuse me, directed the hospital to purchase an HCIS system back in 2000, and the decision was made to purchase Meditech in 2000. And at that time, our home health department was using a product called PTCT. We had, prior to that, lots of disparate systems that sort of focused on specialty areas, specialty IT functions. Meditech went live in 2001 with the financial part. In 2002, the diagnostic and surgery module went live. And in 2002, we implemented our document imaging system, scanning and archiving. and we started using Formfast in 2002. Then in 2004, we went live with the lab module and the nursing module. We purchased mobile carts for the nursing floors for nursing documentation, not for medication scanning. That was in 2005. We deployed the BMV solution in Meditech, which is medication scanning. In 2005, we implemented our OB fetal monitoring system, and we started CPOE. I haven't looked at this slide in a while. We started CPOE in the ED back in 2005. So we have good gains lately over the past year or so, but we started back in 2005. We went live with our PACS system in 2006. We also did cardiology PACS in 2006. We were listed as the most wired hospital in 2007. We purchased and started implementing LSS for our physician practices in 2008. And that takes us up to 2009 when we got the Stage 6 designation. There's other little bits of what happened when on the timeline here, but I think those are the major points. What else? What was
so the follow-up to that was, what did your IT group in size look like in 2002 compared to what you have today?
I don't know. In 2002, I wasn't here, but I arrived in 2004, and I think since 2004, we've added probably only maybe 4 or 5 positions in terms of headcount. I suspect that back in 2000, between 2002 and 2004, there was even more significant growth. So we're at about 28 employees in the IT department now. We were probably about low 20s when I got here. And back in 2002, I'll look around the room. Does anyone know back in 2000?
I don't know the exact number that we had in 2000, but I know that when we started implementing Meditech, we pulled in key people from the specific departments and turned them into IT specialists, IT employees at that time.
Yeah, that's a good point, because the rollout, even though we have a fairly good-sized staff here now in IT, we depend a lot on super users in the rest of the hospital, Meditech super users. Excuse me. And as these modules rolled out, for example, the PACS system, we had some consulting support there, and we had a lot of support from the director of radiology and someone else in his staff. So these systems don't roll out just with IT support. It's IT, usually some consulting support, some Meditech support, and then usually a super user or two from the department that is getting the module turned on.
So do you have any tricks for user adoption? How did that go in clinical and nursing with the docs?
Well, I think, this is Deanne from Informatics. I think, too, we have a very strong partnership between clinical users and IT, and we really, in terms of project management and project implementation, our team is very well-rounded in that area. So that has been really key. As clinicians give feedback to the technical requirements that they have, IT has certainly risen to the challenge and tried to be creative and meet those needs.
Great. What's this meant for you as a hospital, as an IT group? What is the EMR, the electronic medical record, more paperless paradigm? What has that meant for you in business terms, in health terms, in satisfaction terms?
Can I just mention something that we have a monthly physician advisory council, and so CPOE has been a big topic there, and they've come to expect immediate results to be available in the patient record. And when I say immediate, I mean they may not look at them until they round that evening, but I sensed amongst some of our highest ordering physicians that they are starting to expect to see results in the online chart and not have to wait days for processing to happen, for transcription, to see results coming from, say, a specialist. They want to see the results in the chart, in the electronic chart. They don't want to have to go back to the paper chart and try and dig through it and find what was the problem last time? Some prescriptions or something, or in the paper chart, and the doctor made the point very emphatically that information should have been available in the EMR. So we're actually getting pushed now by some of the doctors to go faster on the CPOE.
Certainly, I think that some of the benefits for the patient are just that speed that Joe was talking about that promotes patient safety. It promotes improved patient care. Just that ability to communicate in a much quicker fashion promotes well-being among the physicians, and certainly helps the physicians and all the caregivers to care for the patient. There's no question. Some of the numbers out there in the world promote the benefits of CPOE. There's no question that along with CPOE, certainly the order entry process goes beyond order entry and includes the reporting back to the caregivers. So there are several reports that show reduced complexity of cases with using CPOE by hospitals that have a high technical level. Certainly, I think there was a Texas group that reported even possibly some reduced deaths because of this improved communication and caring for patients. So certainly our goal, as has been probably most all of the organizations that have reached this level to this point, has not been the carrot out there, the dollars and cents, but really that sensitivity with the patient and the provider, trying to do a better job in providing patient care. So certainly the stage 6 has kind of been a little pat on the back for all of our staff, saying, gee, we worked hard. All the super users worked hard in implementing and directing the traffic in their departments. The IT staff says, gee, this is great. We've really tried to build the infrastructure to support that for all of these caregivers. And the Physician Advisory Committee, certainly as Joe says, is now pushing, saying, hey, we want more, we want more, we want more. So those 8 members that meet monthly are always critiquing and pushing us for a higher level of technology.
So you talked a little bit about infrastructure. How is your infrastructure supporting this? Are you getting more equipment on the floors? Are you using scanners? Do you have more access to electronic medical records in different areas? How's that working for you?
I think as far as the providers go, the infrastructure where they're most likely to run into computers is our mobile carts out on the floors. We have I think it's 117 mobile carts. On average, say 10 per department, something like that. And those are fully operational computers with the big 19-inch monitor and full-size keyboard. They have battery power that lasts about a shift. And they run Meditech on those carts, basically. Now, the nursing stations also are pretty fully equipped, I think richly equipped, with PCs. Most nursing stations have a separate island that has 4 or 5 PCs on them, on the island. They'll have a couple laser printers at the nursing station. And then each department has, I think each department has a doctor's reading room or transcription room with 2 or 3 computers in it. So there's a lot of computers around the hospital. We're, like I say, I think we're sort of richly resourced there.
And that has been really important in the clinical arena. Initially, we were not. And so as we realized that we were higher for hardware, we had to ramp that up. And just basically IT and administration was very receptive to that and to just increasing devices as we needed.
Yeah, and I should say on the support side, for example, when I said we went out with nursing documentation in 2004, and our original rollout of carts was 40 or 50. And so since that time, we've doubled it, a little more than doubled. And that really happened. That demand went up instantly with BMV, bedside medication verification. Nursing documentation had some demand for the carts. but it was bedside medication that really drove the increased need in terms of quantity of carts, and then the sensitivity to any sort of errors or, crashing of the cart, PC going down, performance being slow, anything like that. The tolerance for errors on the carts, really, the tolerance became very thin after BMP went out.
I think that one comment that I make often to our tech support area that supports the desktops and the carts is that they're only one person away from the patient. If that cart or if that workstation doesn't work, then that caregiver has trouble providing care to the patient. So, they're not far from that level of patient care that really is our goal and is our drive to provide improved and really good patient care.
Yeah, and so the demanding environment where tolerance is thin then has driven the IT department to be more rigorous about things like change management, appropriate, staffing the right amount of time. We used to cover a couple shifts. Now we cover a couple shifts and a little bit into the third shift. We have someone here just to make sure that when the third shift comes on, if there's any kind of network problem or a problem in the ED, we have someone here at least for the first hour of the third shift. So operationally, we've become, I think, a tighter organization and better able to deliver service in a predictable way to the nursing staff and all the clinicians, because essentially they're using computers as they treat patients. So their demands on the IT department have gone up quite a bit.
So over the past 5 or 6 years, there's been a huge shift from, past processes, which you can probably talk a little more about what your past processes were, to more electronic processes. And how has that affected the management of the medical record, the HIM department, the materials management? And there's a lot of changes that happen when you shift from a paper-based environment to an electronic environment. Can you talk a little bit about that, what your processes were before and after and during the change?
From an HIM perspective, we had a scanning system that was basically just a scanning and archiving system before we went to point of care documentation, before we started updating our forms with Formfast and putting barcodes on the forms and making it a more automated process. Excuse me. And our indexing was all manual. We had to rely on staff to accurately name the form, accurately index the form to the correct patient. Once we started going towards automation, we have barcodes on the bottom of the form that have that recognize the name, so it automatically indexes them. The barcodes are on there for the patient M numbers and account numbers, so it automatically knows which patient to send it to. So it's really decreased our error rate and our I guess you could say, manual processing. So it makes it faster. The charts get in the system faster. Physicians can see the records faster. We don't have a chart completion area anymore. The physicians all sign online. Sorry. And they can sign from their homes. They can sign from their office. They can sign wherever they can remote into the system from.
Okay.
As far as material management, we've reduced our the cost to have outside printers. Paying our outside printers. We've reduced our inventories of having forms on hand. I think our initial reduction was about $65,000 on hand forms. That was a wonderful accomplishment right there.
Of course, at this point, the electronic record is our legal record. There are still those lingering papers that come down, and we have a project active right now that is visiting each of those floors. So many of the sheets of paper that go to health information management are duplicates of the electronic record. So we're visiting the floors identifying what has been sent down in paper form and pointing out and trying to find complications and presenting solutions that say, gee, you know, this is already captured electronically. Why is it that you're printing? Why is it that you're documenting on a form that is already electronic? So that's a project that's going on right now. We are also beginning to identify some of those consent forms and pieces of paper that need signatures in various areas, some of the registration areas and sometimes on the floors. And we're looking at solutions from Formfast that will allow us to actually capture that electronically at all those points.
I have a question from our audience. Marilyn asks, do all your forms print on the floors on demand, and how difficult was this to implement? Was it more or less costly than printing in bulk from a single printing source?
All of the floors do print on demand. They have access to all their packets and all their forms that we have set up for them. I think it would be a lot cheaper than having an outside vendor print your forms. And plus, they can print it with the patient information right there on the actual form. So that saves money on stickers and just different things. So,
of course, being an old salt in this business, I remember the days when everything printed in a central data center, and we always had to separate and then deliver those forms. So even though that was a kind of an old solution, and we're still seeing it happen in some areas, and we're going through each of the areas now, reducing that that remote print function out to the patient care areas. That was a big step and a big step in the right direction, but now, of course, we're eliminating that.
Melissa has just recently attended Formfast training, so even though they are at stage 6 of EMR adoption model, it sounds like they're still moving forward. Do you have an idea of the number of forms that you have done, the number that are remaining to do, your plans in that arena?
Currently, in our Form Central system, we have a little over 1,300 forms. We're going to be converting them all over to the Formfast. So, you know, there's still a long way to go. And there's lots of updates that we're going to do, too. We're going to make some changes on our layout and stuff like that.
Certainly, the Stage 6 focuses on at least these solutions in at least one department. Well, we have the solutions in more than one department, but there are still several areas that we need to work with and find good solutions for.
So we have another question from our audience. I'll pose this to the group here. Sandy asks, how did you accomplish the requirement of giving a patient an electronic record and submitting information to your state regarding lab reportables, etc.? And how has Formfast helped you achieve this along with Meditech?
Okay, now this is Joe. In ARRA, there's a requirement to deliver the EMR to the patient in electronic format. I don't think that was a stage 6 requirement. No. So we're working on that, being able to do that as part of ARRA. But at this time we don't actually deliver. Do we, Sharon, the medical record in electronic format?
Correct, we do not. Right now we're working with, trying to work with Meditech and another vendor to help us due to the limitations we have within Meditech to be able to achieve that status of submitting an electronic copy or giving our patients an electronic copy.
We're participating with Google Health and providing personal health records. I'm also in the early stages of being a beta site for LSS patient portal for the Magic product. So that function will satisfy some of those for our clinic users, but since those clinics are so closely tied to the hospital, general inpatient reports and information should also be available through the clinic to the patient.
Just a little bit of housekeeping here. if you do have questions, go ahead and pose those to the host through the chat panel. And we're just going to kind of start answering some of those questions, and I'll continue down the road of some of the other questions that I had. But Sandy has a follow-up question here. What do you do with the triplicate and duplicate copy forms? I'll put that over here to Melissa.
We do set up some printers to print out on NCR paper. There's a way to go in on Formfast and set it up where it prints so many different copies under one print form name, and you just use NCR paper in your printers. And it works really well, so we usually don't have any problem with that.
One thing we've also done is Melissa will create the form through Form Central if it's one that, we still have to send out to a printer due to some specification that we can't handle internally, is she'll create the form in Formfast, print it out so it's barcoded and has the correct format for the hospital, and then that's what they make the triplicate off of. So we do have some that we can handle internal, but we do have those that we do send out, but they still have our barcode.
To the outside vendors.
Correct.
Yeah, that's correct.
What about the forms that are printed on different color papers? Do you have a different color sheet in a drawer, or have you kind of weaned your users off of that using a code on the page?
Can I just, I'm not sure that this is exactly answering that question, but I know in the ED on discharge instructions, they did go to different color paper and different trays to make sure that, let's say it was the rose colored paper, that all the discharge instructions were on rose colored paper, so there wasn't any confusion, or if you had a packet of 10 pages of rose colored paper and you somehow saw a green sheet in the middle of that, you had a visual cue to look and see what was going on, probably remove the green sheet or the white sheet of paper. That's from a technical from a sort of printer support standpoint. I've seen that in our ED. I don't know if they're still using different color paper based on what they're. Oh, they are. Okay. Yeah, but on the rest of the forms question, I don't know.
But honestly, as we move forward, we've pretty much weaned our users off of different color forms. I can remember we have several different colors we use for different purposes, and as we become more and more electronic, those are addressed in our system. So there's no need to put those in the chart to be identified by different colors. So.
And I have a question here, just asking what version of Magic are you using, and are you using linear or high-density RSS image scanning of medications in pharmacy and the bedside scan?
We're 564 on Magic, and as far as the scanning goes, Meditech. So Meditech will print just the code 128 barcodes, which I'm sure those are linear. We do our medication. The package we use to print the barcodes for the medications does 2D barcoding and linear barcoding, so the scanners read both. It's a requirement that our scanners do linear and 2D barcode. As far as high density, you do have to be a little careful on your scanners to make sure that they have the model we use. The term is special focus, so they're a little shorter range as far as scanning, but they have higher precision for scanning the barcodes, especially the small 2D barcodes. I'm not sure. There may be more definition around what they say high density. High density. I'm not sure what high density means, but I just told you what I know about 2D and the special focus on the scanners.
Do you have a strategy for back scanning, or do you only forward scan?
We have. We do not back scan, but when we went live with our scanning and imaging system back in '99, they went from everything 99 forward was scanned. Anything older was microfilmed or fished. So we are current on all of our scanning. It's either microfilm or scanned electronically in the system.
Yeah, I guess I want to say too. So the question I was answering, I think, had to do with medication scanning on the floor. And then Sharon's talking about scanning forms so there's two different kinds of scanning going on. There's sort of the gun scanning on the carts that we use, and then the HIM scanning that goes of forms.
Okay.
And so much of what we all are doing is that interim to electronic, which is the scanning. And as we continue to grow across the organization, we'll have less need to scan.
Another follow-up question from the audience. How many of the 1,300 forms are currently in Formfast, and is there one resource on site that creates the forms?
That would be me, Melissa. I'm the creator. And they're all in Form Central. All 1,370 some are in Form Central. And they're in different areas, of course, and they're available to different areas. And there's, different packets.
And we have Tim who's asking, he says, I'm curious to know how well healthcare providers accepted printing documents on the floor.
That was a challenge. That was a challenge. When we first implemented it, we visited each workstation, and we had to literally go through their file cabinets because they would hide their old forms from us, and so that we wouldn't be able to find them and put them on the computer.
What could possibly be wrong with that?
Yeah.
Well, all of a sudden you get a form that was last updated 6 months, year ago, whatever. Yeah.
And you're like, where did it come from? And somebody says, oh, I got that out of the file cabinet. Way in the back. Yeah. So we'd have to go out and rate them again. Yeah. You did that 2 or 3 times. Yeah.
Okay, so we have another question here. Let's see. Do you have any forms and booklets? And if you have multi-page forms, does numbering happen in the barcode?
Actually, we do have a number of pages for one form. One of our CPS forms is like 17 pages. The barcode reflects the form number on the form. So we use one form number for all pages, and then the macro number is the number that determines each individual form. But we do have multiple pages.
Okay. We have another question on CPOE. Dave, I think I skipped over this slide about CPOE and adoption. So I'm going to ask you this question. You can talk a little bit about that as well. Larry is asking, are you using CPOE in the outpatient clinics, for example, oncology, CHF, or infusion, with EMR and bedside scan?
We're doing less in the outpatient setting. However, we're working currently with oncology, trying to identify the best system for their product. That's a little one of a kind there. The radiation oncology has their own demands in terms of documenting and progressing through a patient care. So we're looking at LSS. We're toying, of course, with a couple solutions there to really provide the best for that area. They are registered as outpatients. That physician can order through Meditech in the outpatient status, but it's fairly low volume compared to some of the other areas. So it hasn't lent itself to the benefits of high volume ordering.
Can I, talking about the ordering, we're also working on implementing an anesthesia system, and the question has come up about anesthetists, CRNAs, using Meditech to order. And what we're trying to do in that case, because the anesthesia system is not Meditech, because Meditech doesn't provide that module, that capability, is to have the CRNAs order through the specialized system and then interface those orders back to Meditech. So the patient record would show that the order was made and that the order could be handled. If it's an order to the lab, say, then that would go through. So there's a lot of interfacing going on between this anesthesia system, which is from a company called Acuitech, and back into Meditech, and vice versa. Obviously, the demographics are coming across to that system. So even when you have, we're pretty solid Meditech hospital. I mean, Meditech exists everywhere in the hospital that it can exist, but there are still some gaps. And when it comes to ordering, if they're not using Meditech to order, I could foresee that some different departments, if Meditech doesn't have the capability, then you would provide a best-of-breed solution that interfaces with back with Meditech.
Here's a loaded question. It says, is it a full-time position to control the forms?
Well, I think it should be. Is it currently? No, it's not a full-time position.
Right.
But it does take a lot of time when you're initially setting up everything and getting all your forms in there. But after you really get it going, though, you can keep it all updated and stuff. I think in a part-time position.
As you redo those 1,300 forms, how are you? All right, so we don't know yet.
I don't know.
how to redo the 1,300 forms.
So along with that, there's another question here about attaining the next level of EMR adoption, and that's kind of our another conversation. But one user, Ed, in the audience is asking, how is Formfast going to help you along that route to stage 7 and continue in the future?
I think that we're looking at Formfast to satisfy some of those little lingering forms that are sitting out there on the floor. Certainly in the HIMSS adoption model, there is a situation where they don't mind a mandatory form in a department, but they don't want that form in paper form to follow the patient to another department. So Formfast is going to give us the opportunity, using those signature tablets and so on, to actually deal with a piece of paper in a department where a patient has to sign, or there is a requirement for a signature and communication with the patient. We'll capture that in the department. It'll become a part of the electronic record, and there will be no paper that follows the patient.
Also, too, just in terms of CPOE and developing the order set, Formfast was really instrumental in that, because we had all of those order sets already loaded there, and there were hundreds. And so that made it really easy just to move those over to electronic form without having to communicate with every physician on every form initially.
Great, because we have a follow-up question from the audience. Larry is asking, in building your physician order sets, did you use a commercial vendor to assist for templates, et cetera? And how many physician order sets do you currently have? And which medical or surgical services has the most order sets? Big questions.
Yes, we do use it. We use Zincs, for example. And we try to use, of course, the Zincs and UpToDate for evidence-based medicine type of stuff. We use the Zincs order sets, and we modify those and make them available to physicians, and they can then modify for their own particular use. And those are then recorded. I was at a peer review meeting a couple weeks ago where one of the doctors was complaining about the amount of time he had to spend entering orders. And another family physician looked at him and says, "My gosh, what are you doing?" And the orthopedic surgeon says, "Well, I got to enter this, got to enter that." And the family practice guy said, "You can do that with one button." So after the meeting, they got together, and the surgeon was really pleased to find out that he could put his bundle together and actually enter his order set with one button.
I think on that question, though, we don't know off the top of our heads how many order sets we have.
Sure.
Well, lots.
I would say OB, surgery, ED, they certainly already had established order sets, that they were really used to using. So that helped us just to move those over to CPOE.
The surgeons are a little more cranky sometimes in really building their order sets, and we're in the process of expanding those across the board in ED and so on.
And that's one thing the physicians have really liked is with the CPOE adoption, if they have a patient, they come in, they can build an order set on the fly. So that's where on our side it's hard to track how many order sets there are really, because they have a patient come in, they like what they're doing, make it an order set. So it's real easy for them to convert that, and they can ultimately share it with their coworkers if they want. If they're talking, they say, "Hey, I have an order set." We've had a lot of them through our PACS committee saying, "Hey, I want your order set." So.
Yeah, this PACS committee is really satisfying when you get the groups of physicians together. somebody says, gee, I'm having trouble with this, and all of a sudden one of the doctors jumps up and says, hey, start up the computer, I want to show. So we have a show and tell there, and it really helps to mentor from one physician to another.
The other thing I would say, too, like in terms of the process of adoption of CPOE with the order sets, it is valuable to even have someone just go ahead and enter those order sets into CPOE and then, contact the physician and start talking about refining those, because it's very overwhelming to them to start from nothing. And they're so used to having those given to them anyway. So having that started really helps.
First of all, we also have a question, probably a common question from the audience, whether or not these slides and audio will be available to attendees after the event. And we are recording this, and we will make it available as soon as we can reproduce it back onto the web and get links out to everyone. Thanks for the interest in that. Charles is asking, I think the printing on demand is great, but are the physicians impacted by the process?
I really don't think the physicians are impacted by the process. On the paper forms that are out there that we haven't converted to electronic yet, a lot of them print out in packets, or the nursing staff, they know which forms the physicians want or are going to need. So a lot of times they're already out there if that's what the physician's going to request. But more and more since we've gone to CPOE, the physicians, a lot of them don't even look at the paper chart anymore. So they're relying on our electronic process.
At the PAC meetings, we have doctors that say, gee, I haven't looked at a paper chart in 3 years, 4 years.
So then the frustration is when another doctor is putting things in the paper chart, there's a little bit of, miscoordination there.
That's where the nursing staff really has to be alert.
So when that happens and paper gets into the chart, is there any process to get the data into the electronic system, or is that somewhat of a gap?
Currently, our process is after the patient's discharge that we're required by hospital rules here to leave the chart on the floor for 48 hours. We pick it up in HIM and process, and then we scan it and index it. So anything paper really does not get put on the chart till at least 2 days post-discharge.
Mm-hmm. But with that paper, you're probably not collecting the granular data that was in that.
Correct.
Okay. Another question was, what's your forms committee comprised of, and how is your process for changing and version control on the forms?
Well, I'll start off, and then Vicki and Melissa can offer some support. Vicki organizes the forms committee, and we have people represented across the board. Patient accounting, general financial is represented. The clinical is represented. The nursing IT coordinator is there, as well as Melissa and Vicki, myself, and Joe. Health information management is there, and really that's the core, but anybody else who wants to come and bring a form for update, to change, whatever, is welcome.
Pharmacy is a
pharmacy. Forgot pharmacy, yes. I just wanted to add one opportunity. I want to thank Formfast for giving us the opportunity to talk with our peers out there. Hopefully, no one's perfect, and every organization has a real challenge in these times to try to do better. We work every day to try to do better and try to respond to the crises in the health organizations, just as the rest of you do. There are new challenges that come about. ARRA just happens to be one of the most recent, and we're working really hard to satisfy those requirements, but then there are also certainly existing departmental questions and problems that we deal with from an application sense daily. So if you have any questions or comments and you want to get in touch with any of us, please feel free.
I want to thank our audience for participating with the questions, and thank our forum, our group here, for the lively talk. And I'm going to turn it back over to our host, Laura.
Great. Thanks, Sean. I really appreciate it. And again, thanks to Dave and Joe, Melissa, Vicki, Sharon, and Pam. You've really provided some great information today. Our webinar series continues with one more event coming up on July 13th. With the increased popularity of software as a service, we have found many nuances of SaaS contracts that hospitals will need to be aware of. Please join us as we talk to Zach Hammerman regarding these issues. You can register for this webinar at www.formfast.com/springwebinars. And as you leave the meeting today, there will be a brief survey to let us know how this impacted you today and provide more feedback to us. If you have any other questions or would like to contact Formfast, please call 1-800-218-3512 or visit our website at www.formfast.com. Your time is valuable, and we appreciate you taking the past hour to learn more about ARRA funding initiatives and the journey to Stage 7 of the EMR adoption model. Have a great afternoon.